see general practitioners. And then we looked at our records, and nearly 50% of all neonates who come to the hospital had paid a visit to a GP. Another 20% came from obstetric units, and the rest was a mixed population, either the patient coming himself or a relative sending the patient or a pediatrician sending the patient. But that's a very high number, so you're likely to see many of the GPs. And as I said, you don't have to be a scholar to make a diagnosis, you just have to be familiar with some of these things. And then the only important thing that remains for you is to discuss the situation with the parents. They would have certain questions, you would like to have certain information, and then finally, the single most important thing that contributes to very high morbidity and mortality in pediatric surgery is delay. So if you delay the diagnosis or referral to an appropriate center, then that is the single most important thing that is going to contribute to a bad outcome, which may in many cases be in the form of mortality. मुझे pointer दे दें इससे चलें. You can treat adults, and you can treat adults like children, perhaps to their advantage, because you'll be more careful. But the reverse is not true and would always be a disaster. That is why you have to understand that children are not merely small adults, they are different. And that is why time is of paramount importance. You can have an adult or a middle-aged man who may have an intestinal obstruction and may be going from one clinic to another, and after 15 days comes to the hospital and may still make it. That is not true with a newborn. If you delay the diagnosis, then things are not on your side. Next. 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 Now, why is it important for the GPs to know about pediatric surgery? Because developing countries have a huge pediatric population. This is unique in this planet, that Pakistan has 46% population, which falls in the range of pediatric population. So there are three groups of doctors who need to be very familiar with the disease of the children. The first and the foremost, as I said from our statistics, that 50% of these neonates have made a visit to the GP. So the most important component is the GP, then the pediatrician and the gynecologist or obstetrician, whatever you may call them. Next. Now, what is expected that when you see a child with a congenital malformation, you're not merely looking at a child or a deformity alone, because you have to look at the child as a whole, because you remember from your primitive knowledge of embryology that things tend to go wrong simultaneously at many places. So if you have one congenital malformation, it is your obligatory duty to look for others. You have to look at the parents who are totally distressed, and they have all sorts of bad feelings, and they think that they were responsible in some way for the abnormality. They are obviously worried about the future prospects of the child. The marriage itself may be in danger, and a very perturbed immediate family like grandparents are all around you. So you have to overcome all these problems, not merely identify and diagnose. Why do I say that? Because once he goes out of your clinic into a very busy tertiary care hospital, then unfortunately nobody has the time to talk to the family. So it creates a lot of difficulties when they walk into the hospital not knowing anything about the disease. Actually, this discussion should have started much earlier, because patients have a lot of confidence in their general practitioner or the family doctor, as they say. And in cities at least, as you're lucky that you're working mostly in the cities, now there are a lot of antenatal ultrasounds being done. And nearly 27% of our neonatal abnormalities were diagnosed wrongly or rightly before birth. So the patients may come to you seeking advice about even the delivery. Before you see the patient, they may seek advice from you about the delivery of the patient. That is why you have to know about the common things. Next. Parents, as I said, have a feeling of guilt and also have a lot of social embarrassment. You've just to meet the parents of a child who's born with a bilateral cleft lip to understand they don't want to take him home because they don't want to expose the child to their family. Then, as I said, for the child, it's very important to identify the associated malformations, some of which may be very minimal and insignificant, but they may be very serious. They may not be compatible with life. You may be sending a patient home who has a very serious cardiac anomaly and may not even survive the first few days. There are some congenital malformations in which we wait for 3 to 4 days so that we are able to make a diagnosis of compatibility with life or not. And the typical example of that is cloacal exstrophy. We don't operate on them immediately because some of them may be identified as having congenital malformations incompatible with life. Then obviously the parents are not only concerned about the immediate outcome, they also want to know in today's very competitive world what is going to be the intellectual development and how is he going to perform in school, because they want to see their child as a successful citizen of the city or of the country. They just don't want a living soul around who is no good for the family or for the society. And then we have to identify the potential for independent life and the risk of some residual functional defect. I am talking about here the very common meningomyelocele that you all see very often. It's not merely sufficient to tell them that your child would need a surgical operation and that's the end of it. It is unfortunately only the beginning of it. And they must know before the treatment starts what is in store for them subsequently next. So the doctor has a very high responsibility and a very responsible role, not only as a physician but also as a social worker. I always say in developing countries there is a lot of room for leadership, and we, being the most lucky people who've had an opportunity of getting educated, who are making a decent living, have a lot of role to play as a social worker. We have, why do I say this? Because you are the one who's going to tell the family that no solar or lunar eclipse was responsible for the hemangioma or the cleft lip. That is a lot of good social work, but you would only be able to tell them if you have confidence in your own knowledge. Because at present, unfortunately, still people attribute most of these things to the mother. Because the mother wasn't careful, she went out, she got herself exposed to it, and therefore she is fit for getting a divorce because she brought this abnormal child into the world. And that is the social work that you must continue to do. Then obviously you must tell them about the chances of recurrence in subsequent pregnancies and advise them on family planning, avoiding pregnancy when they already have a complete family. I get patients, the mother is 37 years old, they already have 3 daughters and they want to have another pregnancy. Then you have to tell them about every bad effect of pregnancy. They're generally not interested in the bad effects on the mother, but if you tell them there's a possibility of getting an abnormal child, then they listen to you. And the highest incidence of Down syndrome is in older mothers. So you can frighten them by giving them examples of Down syndrome. Then you educate them. Now this was a complete family. Now you have the firstborn who's abnormal. So then you need to tell them about the antenatal care in future and the harmful effects of drugs in pregnancy. Most of the doctors don't prescribe drugs in pregnancy. What happens is that homeopaths and the Greek medicine practitioners, they would always add allopathic drugs in doses that are not known to them in their concoctions, and that can give rise to all sorts of problems. You must tell them. I have seen patients who had arthritis and they were given loads of steroids by Hakims, and the mother gave birth to 3 consecutive cleft lip patients, which was totally avoidable. Because you must remember that congenital malformations are a mixture of genetic predisposition and environmental effects. You can't change the genetics, but you can prevent the environment, the adverse environment, so that you don't get the outcome. What we are interested in is the outcome. So we must work where we can. And when you look at malformations, you have to communicate with the family who's in distress and emotional instability, and you have to develop your communication skills. So that is the importance of some of these workshops that you attend. Next. Now with that background, I thought it would be very important to give you the principles of managing and looking at a child with congenital malformation. So these are the principles in the background. Now out of the 60% patients who had made a visit to the GP before coming to the hospital with neonatal problems, the highest incidence was of neonatal intestinal obstruction. So you should all, why is the reason? What is the reason for that? Because generally some of these obstructions may not be apparent in the obligatory 6 or 8 hours stay for the baby in the private clinics with a normal delivery. So they all end up being sent home without making the diagnosis. And then the next day or the day after, they spit a little bile and they go to their family doctor. That is where the importance of the family physician lies in identifying these conditions very early. We'll see how. Next. As you all understand from your knowledge of surgery and medicine, intestinal obstruction is a clinical syndrome. classically is described in adults as absolute constipation, vomiting, abdominal pain and distension. What the patient comes to you often is with abdominal pain and distension, complaining of constipation when you inquire. If you call back on your knowledge, this is what happens most often. Now, how does that differ in the neonate? It deviates to a considerable extent because you have to understand that children are different. How are they different? They cannot communicate, they cannot explain the complaints, they cannot tell you that they have a pain in the tummy, they cannot tell you that they have nausea and they feel like vomiting, they cannot tell you that they are constipated. If the mother is observant, she probably will be able to tell you some of these things. But as I said, at times the child is not being looked after by the mother, it's being looked after by somebody else, and they may not be very attentive to all these things. So the responsibility lies on the attending physician to pick up subtle signs and symptoms and then to make a diagnosis. Next. And what are those signs and symptoms? As I said, the responsibility is yours. It will only be possible if you are aware of the spectrum of pathology and symptoms. The key is training and exposure. It works out just like a computer. You have to put in the data and you can recall the data. If there is no data in the computer, then the computer can't do any wonders. So your brain is again like a computer. You have to put in a clinical data. And then there are distractors. You put your stuff there, but something different comes. I call them distractors. They may not let you synthesize the information into something sensible. Next. Simultaneously, you work in different directions. You try to make a diagnosis, and as I said, your job primarily would be confined to making a diagnosis or even a suspicion. And then you have to identify whether you have to send this patient for surgery or to hospital or to a medical or a surgical unit, and to prevent complications while the patient is going to the hospital. So these are the three aims that are before the end. How do you establish the diagnosis? I'll just give you the key answers. Any or green vomiting in the newborn is intestinal obstruction unless proved otherwise. This is a very frequently asked MCQ. When should you refer for surgery? Immediately. If a child is vomiting green bilious aspirate or is getting a green bilious aspirate with a nasogastric tube, you should send the patient immediately to a tertiary care hospital. How do you prevent complications? You must pass a nasogastric tube, because on the way the child will probably aspirate and die from aspiration or get a very bad pneumonia. One thing, you must pass a nasogastric tube, and the other thing, we live in a country which has extremes of temperatures. So you must be worried about the body temperature of the neonate. The neonates would acquire the temperature of the environment, whatever is the temperature around them. So in winters, they tend to become hypothermic very quickly, and in summers, they tend to become hyperthermic very quickly. So the only two things that you need to look into is prevent aspiration by passing a nasogastric tube. Don't get into IV lines, don't get into antibiotics, they don't do anything. Just send them quickly to the hospital. And make sure that on the way to the hospital, they may have to travel in different modes of transport. They may have to spend an hour or 2 hours in reaching the proper hospital. So you want to make sure that in those 2 or 3 hours, nothing unwell happens. And for that, you have to prevent aspiration. You can pass a nasogastric tube. And you have to prevent hypo and hyperthermia. Don't do anything more than that. That is all that is required from you. Next. As I said, the diagnosis is mainly clinical. Casual attitude is the only problem. You have 200 patients, a neonate comes, the mother says he's vomited, and you say, okay, give him Gravinate. That is never going to work out. You must have time to look at the child, and because any casual attitude can lead to a wrong interpretation, which can be fatal and cause irreversible delay. These are the errors that must not be committed. This I think may not be very relevant in the present setup, because this is for an area where you may keep the patient for a child. This is very important. You must ask the mother that was the distension there at birth or did that come subsequently, because most of the obstructions of the small bowel would allow the baby to develop abdominal distension antenatally, and the child would generally be born with distension. It is only the very high obstruction in which there would be no distension. Next. Now, one very common thing that is missed very often is tracheoesophageal fistula with esophageal atresia. If you look at the textbooks, they would say that the diagnosis is often made by the nurse. Why? Because the nurse sees that this child is unable to swallow its saliva, and that's continuously dribbling from the corner of the mouth. This is called drooling of saliva, and all you have to do is pass a nasogastric tube. You will not be able to pass a nasogastric tube in these patients. The incidence is not very uncommon, it's quite frequent, and unfortunately the incidence of nearly all congenital malformations is very high in Pakistan. Pakistan probably has the highest incidence of cleft lip and cleft palate, club foot, tracheoesophageal fistula. At least that is what I've already been able to collect. I don't know the reasons for that. I think it may be cross marriages in the same within the family and all those things. And I'm very confident the prescription of drugs by non-allopaths is one major factor for all these abnormalities. Do not investigate this patient. It's not your job. If you see that the child is unable to swallow the saliva, you shouldn't really go beyond that. Do not waste any time. Urgent referral is the key to success. Why do I say that? Because they all tend to aspirate, and they all tend to aspirate from the stomach through the fistula that they have in the lower esophageal pouch, and they have this acid going into their lungs which literally eats away the lungs. And once a child comes to us with bilateral pneumonia which is induced by the gastric acid, then it's fatal. And unfortunately, for the same reason, our results are not very good. We have about 47% survival. But the reason for that is that the oldest patient that I have operated on for a tracheoesophageal fistula was 29 days of age. And that probably, I have not been able to find any reference that child survived. We're going to report that, and probably that is the oldest survival of tracheoesophageal fistula in international literature. But you see, that's a chance, that's an unusual thing. Most of them would die. So your job is to prevent aspiration pneumonia. The only way you can prevent aspiration pneumonia in these children is by sending them to the hospital earlier, because they're going to take some time in the hospital also before they can be operated. Once they have full-blown bilateral pneumonia, so then this is your MCQ. Bad indicators for outcome are low birth weight, associated abnormalities, and pneumonia. If they have birth weight below 2 kilograms, if they have associated cardiac anomalies, if they have bilateral pneumonia, their outcome would be bad. Next. This is, I'm just giving you, I don't advise that you actually do them, but just to give you a complete understanding that if you try and pass an nasogastric tube, it will stop here, because there's nothing beyond that. And you see, this child already has pneumonia. We hardly ever get a patient without pneumonia. Why is there a pneumonia? Because this is stomach, and the stomach is going up here and joining the trachea. There's a very small esophageal component here that joins the trachea. That is why through the trachea they have this gas. Otherwise they don't have an esophagus. So you can easily make a diagnosis. Next. Next. So this is what we did in this patient, and he has an excellent outcome. Here is the place where we made the anastomosis. He'll have some reflux, he'll have minor troubles, but that can all be managed. And the next question is that what are the problems these children tend to have subsequently? All of them have reflux. Their reflux can be massive, it goes all the way, it can go into the lungs. I have two patients who were actually treated by doctors in Jhang for tuberculosis, because they thought that their cough doesn't go, but they were post-operative tracheoesophageal fistulas. They didn't have tuberculosis, they had reflux pneumonia, but they put them on antitubercular. That is why you need to know the history, and if a child has had this esophageal repair, he's likely to have reflux. Next. Now, as I said, any child who vomits green, who vomits bile, has an intestinal obstruction. So they'll come to you with this. What you need to know is the antenatal history. So that will be a short question. What is the antenatal history? They'll ask you, do they have polyhydramnios? Yes, they all have polyhydramnios, nearly all. The other question would be, do they have oligohydramnios? Practically never. Do they have a positive family history? Duodenal stenosis, duodenal atresia, and malrotation have a family history because this is familial. And then antenatal ultrasounds would show what? We are used to seeing double bubble or dilated intestine, but in antenatal period there is no gas to be swallowed, so they don't have air fluid levels, they have distended loops. I'll show you some. And you have a very high accuracy of antenatal diagnosis. This is another MCQ. Do they have a high accuracy of antenatal diagnosis? Yes. Next. As I said, you have to look for the signs. They have a distended abdomen. This distension may be upper abdominal or generalized. They have respiratory distress because the diaphragm is stented. And you may only be asked to differentiate between surgical and medical conditions, medical would be early onset sepsis. But it doesn't make a difference whether you send a medical patient or a surgical patient to the hospital, they're all going to end up in the appropriate section. What is important is you must not miss. If a child has green vomiting, has distension, has respiratory distress, he needs a surgical evaluation and probably hospital admission next. And then you have to identify so many things. You may be able to palpate on superficial palpation, distended loops of bowel, masses in meconium ileus, and all these are just indicators that if you see any of them, you have to send them to the hospital. Don't waste time on any medicines or anything, because rigidity is a very bad sign. It is generally absent in the newborn, but if it sets in, that's too late. Next. So we are used to looking for rigidity. Don't look for rigidity in the newborn. Look for all the other things. Similarly, gray appearance on the abdominal wall is late. It means gangrene. But we still get patients. Don't worry about bowel sounds, whether they are absent or not. It is not important. You are used to looking for high pitched, louder bowel sounds in the adult with obstruction. That doesn't happen in the child. So you don't have to worry. What may happen in the child is a full scrotum. If they are perforated, everything, because they have a patent processus vaginalis and everything goes into the scrotum. There may be scrotal distension before the abdominal distension. So you have to look for that. Don't try a PR in any of these patients. Next. Now, as I said, there are some distractors. We've made a rule that bilious vomiting is obstruction, but there are some conditions in which there will be no bilious vomiting. You can imagine that is common sense. If there is anything proximal to the duodenum, that would not give rise to any bilious vomiting, and that would be a pyloric atresia. This commonly is associated with certain skin disorders. Then you may have pyloric webs, but the important thing is that you are unable to feed the child. He is not accepting any feed. Whatever you give, he throws up. And then you have rare duodenal atresia, which are proximal to the insertion of the common bile duct. But the important thing is that if they persist with non-bilious vomiting, they still need treatment and they still need to be looked into, because vomiting in the newborn is dangerous. They are unable to throw it out. They may actually take it into their lungs and get very bad pneumonias. Next. This is pyloric atresia. Next. Again a pyloric atresia. Next. This was ascites, and this is a little air in the stomach that is floating in free water. So that was a distractor. This was basically ascites. Next. This is malrotation. You have the shadow in the stomach and you have the shadow in the duodenum. Next. 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 Now this is the ultrasound. You're not looking for any air in there. This is fluid filled. Fluid appears black on the ultrasound. This is the stomach and this is the duodenum. And you see there are smaller distal fluid collections also. So this is not complete duodenal obstruction, but this is malrotation, in which a little air goes down, and in this case a little fluid goes down. Next. And this is the X-ray of the same child. When he was delivered, he had the stomach, he had the duodenum, and he had smaller other small bowel patterns right up to the rectum. So we knew this was not duodenal atresia, this was malrotation. Next. आगे चलते जाएं. This is only for completion. इनको हम skip कर लेंगे. आगे चलें. Now this is another next. इसको भी छोड़ दें. Now this is another condition that you see. It's very interesting that we had the study in which 37% of the patients who presented with imperfect anus, never did a doctor look at the bottom. The child was sent home, the child started vomiting, and he had distended abdomen, and nobody had looked at the bottom. So all you have to do whenever a child is vomiting, is distended, you must ask the mother, has he passed normal meconium? Or in case the mother is not there, you must always look at the bottom. There are so many conditions. This is the commonest intestinal abnormality, imperfect anus, and there is a possibility that there may be a covered anus, there may be a small anal opening, and there may be a micro anus. So you have to carefully look at the bottom in all of these cases and must not miss. I've had patients who've actually perforated and had imperfect anus, and they've been going and seeing their doctor frequently. Next. Again, a very low imperfect anus, missed for 7 days. Next. This meconium ileus, इसको छोड़ दें, आगे चलें. मुझे आगे चलें. Next. Next. Now, regarding the GI, as I said, you are only expected to make a diagnosis and time it. In all obstructions, once you made diagnosis of an obstruction, the patient is safer in a hospital. You shouldn't really attempt any medical treatment with these cases. And now the other common conditions, we're just going to touch on a few of these common conditions, because obviously you can't really discuss the whole congenital malformation. So I thought what you see often would be discussed here. I'm sure you see this very often. This can be small. Next. or it can be affecting the tongue and the airways. We had to do a tracheostomy in this patient. He had Down syndrome also. Next. Or it can be massive. So what do you really need to know about cystic hygroma? You need to know what is it basically. It is a failure of the normal development of communication between two systems of lymphatic drainage, which are basically the jugular systems in most of these cases. That is one thing. Secondly, it can interfere with delivery, because if they are too massive, then they don't allow an easy passage of the child through the birth canal. Thirdly, you can imagine that this thing is pushing out so much, it must also be pushing in, and the child has a very thin trachea. The cartilaginous rings are very compressible and they can easily be occluded, so they may have severe respiratory difficulties immediately after birth. Next. So what do you really need to know about these patients is, you need to know about these patients is that when should you advise them to see? If they have respiratory distress, then they need immediate attention. We actually may rupture some of these cysts and save the child from respiratory distress. If the labor is difficult, again, the person who's going to puncture the cyst has to be in the labor room. Otherwise, we tend to operate on them between 3 and 6 months of age if they're not causing any immediate concern. The reason for that is that cystic hygromas invade nerves. That would be another MCQ. Cystic hygromas do not follow any planes. They invade nerves and they invade muscles and they invade every tissue on their way. The vessels are larger vessels. So you want the vessels to be a little bigger, the nerves to be a little bigger, because if you leave behind anything, that tends to regrow. So the appropriate age for operating on cystic hygromas is anything between 3 to 6 months if they are not interfering with the airway. Associated with the cystic hygromas are the vascular cutaneous anomalies in children, and this is a typical hemangioma. This is another one. This is the capillary variety, and this is localized, which used to be called cavernous hemangioma. That's an outdated classification. They are either low flow or high flow vascular malformations. These are all low flow malformations, and they would include, number one, what you call a strawberry hemangioma, what you call a nevus, a vascular nevus, and what you call a lymph hemangioma, or a vascular or a venous cavernous hemangioma that used to be called previously. The treatment for these is simple. This needs to be observed. All hemangiomas, the natural history, that's another question. What is the natural history of hemangiomas? They tend to regress and they tend to spontaneously improve with time. You don't need to treat them in over 90% of the cases. They would spontaneously improve. Capillary nevi, again, you don't need to treat them initially, but around puberty, when they become darker, they respond very well to laser. And these are the localized venous malformations that can easily be removed if they are smaller. Next. This is a typical hemangioma. If you observe that, this is going to disappear in time. The time would be about 3 to 4 years of age. They tend to grow in the first year with the child, but then ultimately they tend to regress. And finally, next. Now this is somebody has injected. It was not necessary. It would, if you just observe, these are the whiter areas of skin that is appearing. That means this area. That means that regression has already started. All you need to do is observe and prevent trauma. Next. Even this lesion, this big, which looks very dramatic, has started healing and would ultimately become something like this. Next. This is in advanced stage of healing. The child is now 2.5 years of age, and we expect that by 3.5 or 4 years of age, this would totally disappear. You see, this is becoming almost like normal skin. Next. This is also started healing. You see the white here. Next. This is a condition which is encroaching on the eye. Now the question is that if they are encroaching on vital structures, then you may have to treat them. The treatment in these cases is steroids, which responds to which they respond in about 60% of the cases. If they do not respond, then you may give them alpha interferon. That may work in another 30% of the cases. But here you can use a combination of treatments. He has multiple hemangiomas. You may inject them, you may give them steroids, and you may give them alpha-1 interferon. Next. This is a capillary nevus. Don't do anything till she becomes fit for laser therapy. Next. This is a small localized venous malformation. We can inject them with STD, or even if it's not on the face, then we can remove that. Next. This is something that you can't do anything about. This is the platelet trapping hemangioma, and that is another MCQ, that you have a large venous component hemangioma, that is a platelet trapping, and they tend to die in the first year. Next. Now this is another very, very vital area. You see jaundiced newborn, what do you do? Surgically important causes are biliary atresia and choledochal cyst. If you don't treat them in time, they all proceed to liver failure. Biliary atresia would proceed to liver failure in about 15 months, and the child would be dead by 2 years of age. Choledochal cyst would start showing signs of cirrhosis of the liver in about 2 years. So this is very, very vital. Biliary atresia, if you don't operate in 2 months, the chances of cure practically diminish to 20%. And if you don't operate them in the first 3 months, practically the chances of conventional surgery are 0. And then the only thing that can save them is a liver transplant. Next. So please do not waste time. If you have conjugated hyperbilirubinemia, that's a red flag. They have to be investigated and treated within the first 2 months of life. Next. Cleft lip and palate, as I already said, is a very distressing deformity. It has excellent results. I think we have much less time. I'll just quickly go through the photographs next. It can look very, very distressing. Next. This is a 17-year-old, again untreated, actually had a couple of operations that failed. Next. But it can have a reasonably good outcome. You can see the nose, you can see the lip, and this is only one primary procedure. We're going to repeat that. Next. And you have a decent result. Next. And you can have a very good result in the newborn. This is the same patient that you saw earlier. He only needs a little revision of the nose. Next. This is again one stage repair. The nose is totally corrected. Next. Then a very important issue of spina bifida. You are apparently looking at a child with a swelling in the midline on the back, but that is not the enough story. It needs explanation of the neurological deficit, because they may have neurological deficit below the lesion. You have to make them understand the limitation of treatment, because it's not going to cure the patient. You have to tell them about the cost possibility and the duration of treatment, because it may continue for years. The role of malnutrition and pregnancies in quick succession of the mother, because malnutrition has been contributing a lot of patients to this group of patients, and folic acid deficiency in particular makes you prone to give birth to spina bifida children. And the size of the family and the interaction between parents and children in the family is very important. Next. You have to tell them about the chances of recurrence, that if they have one child in the family, they have a 3-fold higher chance of giving another child born with the same difficulty. If they have more than 2, then there's more than a 50% chance of having another child affected. So if they have a complete family, they shouldn't really be looking towards having more children. Then the importance of planning next pregnancy and starting folic acid before pregnancy in a dose of 4 to 5 milligram per day, and antenatal diagnosis and termination of pregnancy if they have a major abnormality. Alpha fetoprotein assessment also plays a role in that. Next. Now, a very common thing that you see very often in your clinic is inguinal hernia. It generates a lot of confusion, because parents would ask you repeatedly, is there a possibility of treating this with medicine? Would that be alright on its own? It doesn't ever close on its own. There's no chance of spontaneous closure. The highest number of complications take place in the first year of life, so there's no point in delaying the treatment either. In inguinal hernia, you should offer treatment immediately. So the timing of treatment in your MCQ would be the moment it's diagnosed, unless not fit for surgery. It has to be repaired as soon as possible. There is the additional risk of testicular gangrene if obstruction takes place, which is not the case in adults. They would only have gangrene of the bowel, but the newborn can have gangrene of the testes, and that really frightens them. If you tell them this, then they agree to surgery earlier. Age does nothing to help closure. Next. Why is there confusion? Because umbilical hernia has the same name as hernia, and that tends to close. So people would ask you, all umbilical hernias close. They tell me you don't need surgery, but you have to explain to them that that is because of a patent processus vaginalis and is not going to close, whereas an umbilical hernia is a scar that would contract and gain strength and close. Similarly, all vaginal hydroceles, by vaginal I mean here surrounding the testes, tunica vaginalis hydroceles, there is a very high chance, nearly 90% of self-cure. So these are the two things that confuse them. Umbilical hernia would close by 4 years of age in 90% of the cases. Vaginal hydrocele would correct itself in 90% of the cases by 2 years of age. But inguinal hernia would never close. Next. Undescended testes, I get patients 7, 8, 10, 12 years of age where they've been advised to wait till he gets some strength and would allow the testes to, it would never. The testes can only descend spontaneously up to the end of 1 year of life. After 1 year, there's no recorded incidence of descent spontaneously. You must bring it down by 20 months of age, because at 20 months of age, you have microscopic changes which would predispose to infertility. So the ideal age for treatment of undescended testes is between 1 and 2 years, because after 1 year, there would be no spontaneous descent, and by 2 years, there would be already microscopic changes which would be irreversible. You must differentiate retractile testes. Next. Club feet, again a very frightening thing, but you need to tell the parents about the prognosis, and you would only be able to tell them about the prognosis if you can yourself differentiate between idiopathic and neurological variety. There is some association with spina bifida, so you must look at the back. If it's a neurological variety, it has a totally different treatment. If it's an idiopathic variety, then it has an excellent prognosis and must be treated early. You must look for associated disorders, which in this case would be arthrogryposis, which again would have a very guarded prognosis. Timing of surgery and the treatment of it starts immediately at birth with conservative treatment, and now it's proved that the early you operate, the better is the outcome. I operate on them at 1 month of age, and I think that should be the policy generally. You must tell them that they have to be mentally ready for a long treatment, because it's not a one-go treatment. It has to continue till maturity of the skeleton of the foot, which is at puberty or 15 years of age. There is a high chance of recurrence if they don't follow the treatment. So the after treatment following surgery is fairly prolonged. They have to have prosthesis, they have to have special shoes, they have to have plasters initially. So this all must come from the GP before they end up in a hospital. Next. And one final, I think this should be the final thing, is hypospadias. I'm sure you see that often. In hypospadias, what are the issues? The issues are that the abnormal opening, which in this case is here, may be very small, and if it remains small, it is going to cause back pressure, and ultimately I have seen patients of hydronephrosis with meatal stenosis. The other thing is that this opening remains here, and for normal fertility, the adult has to be able to deposit seminal fluid in the posterior fornix of vagina, and if it remains here, then these adults would have lower fertility as compared to their normal counterparts. Secondly, if it doesn't show in this case, there is an element of Caudy with all hypospadiasis, which is higher with more proximal varieties, and that Caudy means that the penis is bent. The tip of the penis looks down, and with Caudy it's not possible to have normal intercourse. And the most famous person who failed to have children out of 4 marriages was the King of France. Ultimately somebody corrected his Caudy and he had 7 children. So it's not something that is without a functional disorder, it has a functional component also. The timing for surgery in hypospadiasis is it must be completed before the child goes to school, because this is a simple variety. This will probably be a one-stage operation, and you can just correct the Caudy, you can make a tube, and you can make a nice decent looking penis in one attempt. But in severe cases it may need multiple operative procedures. Next. The principles are that you must correct the Caudy, you must correct the proximal meatal insertion, and you must improve the look of the penis, and obviously you incorporate in your treatment a circumcision. The treatment must be completed before school. Next. मेरे ख्याल में this would be the last. Next. देख लें अगर कोई और है कि नहीं. I think that's it, because I thought 30 minutes is very difficult to cover all congenital malformations. We can discuss a few